ectopic. যখনই মেইন জিনিস যেটা সাইট, ইউটেরাইন ক্যাভিটির যে সাইটটা সেটা যখন ইউটেরাইন ক্যাভিটি নরমাল ক্যাভিটি যখন না হবে তখনই আমরা এটাকে বলবো হচ্ছে ectopic pregnancy। এখন আসলে ইনসিডেন্সটা কি? ওয়ার্ল্ড ওয়াইড আমাদের এটা ইনসিডেন্স হচ্ছে 3 to 4%. In some country may higher the incidence. এবং ectopic হচ্ছে in last 20 years frequency or incidence ectopic rises. Why? Because predisposing factor that the PID, ART, and artificial reproductive system, these are increasing. And simultaneously, diagnostic procedure or diagnostic technique are improved. So, we can diagnose ectopic more. And so, incidence are rising. And ectopic is the one of the leading cause of maternal death. And in that cases, here the diagnostic procedure can save the life of the mother about 80%. Previous to today's, 80% mothers' lives are saved by diagnostic, early diagnostics and treatment facility. These are improving. If one ectopic, then chance of further ectopic is more. That increases the 7 to 10-fold than the non-ectopic pregnancy. So what about the intrauterine pregnancy? Yes, after an ectopic, 50 to 80% chance intrauterine pregnancy, but 10 to 25% chance ectopic pregnancy, and remaining 10 to 15% patients are infertile. Then consequence of ectopic pregnancy, intrauterine pregnancy হচ্ছে 55 to 80%, ectopic pregnancy হচ্ছে 10 to 25%, আর infertile 10 to 15%. Site, the common site are fallopian tube, and you know that part of the fallopian tube isthmus, fimbrial end, from fimbrial end, outer to inner to the shape, lateral to medial, fimbrial end, ampullary part, then interstitial part, isthmus, and then interstitial, 4 part. Fimbrial, ampullary, isthmus, and then interstitial. This is the common site for the ectopic. 97% ectopic occur in the fallopian tube. Others, ovary, abdominal. Ovary is the site. Abdominal is usually secondary, but abdominal pregnancy is the secondary. And cornual, cervical, and another one is the rare uterine scar of previous cesarean section. It's the rare side of the ectopic pregnancy. Now we talked about the etiology. Why ectopic occur? Ectopic due to any factor that hamper the tubal function, tubal motility, that may lead to ectopic. And in most common cause, PID or sarcoiditis. Most common cause. Here, the infection occur in the tube, and that may lead blockage of the tube, a partial blockage, complete blockage, adhesion, peritubular adhesion, that ultimately give rise to ectopic. And some of the organisms that are responsible for the PID, pelvic inflammatory disease, chlamydia, gonococcal, tuberculosis, these are the main cause. Another is the gynecological abortion, post-abortion, postpartum, even surgical appendectomy, secondary to infection. Any infection may cause PID, which ultimately leads to ectopic pregnancy. Another cause is IUCD, intrauterine contraceptive device. We use intrauterine contraceptive device for prevention of the pregnancy, but it causes ectopic. How? Intrauterine contraceptive device prevent intrauterine pregnancy, that raises the risk of the ectopic pregnancy. And you know the intrauterine contraceptive device are two types. Copper T is usually used, and another is hormone releasing intrauterine device. In a sense, copper T prevent intrauterine pregnancy as well as ectopic pregnancy. Copper itself, the toxic effect on the sperm, ovum, blastocyst, so it prevents intrauterine pregnancy as well as ectopic pregnancy. But hormonal IUCD, they are acts by functioning they mainly the tubal motility and tubal function hampered. So when it affects the tube, then it causes ectopic pregnancy. Now we talked about the artificial reproductive technique. It is increasing nowadays and increasing the number of ectopic. Artificial reproductive technique, in case of IVF, in vitro fertilization, then the embryo are directly transferred to the tube, or other media catheter disposition, catheter position, media transfer, volume, these are directly affected the implantation side or hamper the normal implantation. And side by side, pre-existing tubal patency, pre-existing tubal damage may provocated the ectopic pregnancy. Here say that histologically proven that in case of ectopic pregnancy, 50% are suggested histologically, which is suggested that the PID are associated. And in case of artificial reproductive technique, this patient are suffering some type of PID or tubal damage. So ectopic is more than artificial reproductive technique. Another was surgical, that when we do the tubal block, when operation for the tubal block, reversal of the tubal ligation may cause it ectopic. And after tubal ligation, it's may provocate the ectopic. It's after ligation, it depends on the procedure or method which follow the tubal ligation, and after residual length of the tube. If we use cauterization in case of tubal ligation, then the chance of ectopic is more. But mini laparotomy, the traditional mini laparotomy, the chance of ectopic is less. Side by side, reversal operation, after reversal operation, ligation and reversal operation. When one time patient ligation, done ligation, then she want pregnancy, reversal operation done, and in that cases, chance of ectopic is more. And we also discuss about the previous ectopic. Previous ectopic, the chance is if patients suffer from ectopic, then it is 7 to 10-fold, sometimes 13-fold increases the chance of ectopic. Why? That's the pathology that causing the ectopic is the same. After one ectopic, it does not remove, it will continue. So another tube or another ectopic are usual. And sometimes when we do ectopic operation, treatment of ectopic, salpingitis, sometimes we do, it's advised there with salpingitis, মানে salpingitis means টিউব কেটে ফেলা হচ্ছে যেটা, সেটার সাথে সাথে বলা হচ্ছে সেম সাইডে ওভারিটাকে স্যাক্রিফাইস করার জন্য, তাহলে হয়তোবা ectopic-এর চান্সটা কমে আসতে পারে। এছাড়া আরো যেগুলো আছে, ডেমোগ্রাফিক যদি ধরি আমরা, এজ, পেশেন্টের এজ হচ্ছে একটা বড় ফ্যাক্টর। মোর দেন 35, 45 years patient have more ectopic because chromosomal abnormality, ovum are chromosomal abnormality, and the abnormal ovum or fertilized ovum implanted the abnormal site. And patient personal history, smoking. It's rare in our country. Our female are not habituated to smoking, but Western country or others country, they are habituated to smoking. And smoking, if a female person take 20 sticks per day, then increases the chance of ectopic is 2.5%. And main pathology, the nicotine. Nicotine damages the cilia of the tube, and ultimately may cause ectopic. And racial factors, demographic factor, non-white people like Asian, they are more vulnerable for the ectopic. We say about the tubal at the most common site of the ectopic. And ampullary part, fimbrial part, ampullary part, isthmus, and interstitial. Ectopic occur in the fimbrial part at about 17%. Most common site for the ectopic is ampullary part, which is near 55%. Interstitial are less common, 3, and isthmus near about 25% isthmus. This is the common site for the ectopic pregnancy. আমাদের কি মনে আছে যে মানে কিভাবে জিনিসটা হচ্ছে, আমাদের কোথায় কি জিনিস হয় নরমাল প্রেগন্যান্সিতে? Anybody can tell me what happened in normal pregnancy, where the ovum fertilized and where is the implantation traverse the root?
Fertilization occur in the ampullary region of the uterine.
After ovulation, fimbria pick up the ovum. Okay, fimbria pick up the ovum, and then it go into the pass through the fallopian tube and ampullary part. There's the fertilization, and they come through the interstitial part, and the umbilical. And this time it takes 4 days, and implanted blastocyst is the form of implantation. Implant into the uterine cavity. implantation, there's the changes in the uterine, uterine cavity or endometrium. What is the change in ectopic? As this implantation occurs at the tube, so there's a changes in the tube and as well as uterus. These are the main two organs that the changes. In tube, there is a implantation occur in the endosulfins. It ovum buried into the endosulfins and trophoblast are invaded the endosulfins and ultimately muscle. As a result, residual reaction occur, but this residual reaction is not sufficient to prevent or limit the trophoblast invasion. Trophoblast invaded into the endosulfins and the muscle layer, and there's distended the tube, eroded blood vessel inwards and eroded the blood vessel by causing bleeding. In this distended tube covered by the peritoneum and stretching of the peritoneum may cause pain. It's the earliest sign. Patient feel uneasiness, pain in the lower abdomen. In a nutshell, there is a distal reaction occur in the endometrium. Distal reaction occur in the tube. And trophoblast, there's a distal reaction is not effective, but পর্যাপ্ত পরিমাণে নয়, যেটা trophoblast limitation prevention invasionটাকে লিমিট করতে পারে, যার ফলে হ্যাম্পারটা বেশি হচ্ছে. At the same time, tubular muscle coat are hypertrophied, but not so. It's a thin layer, so it cannot prevent the trophoblastic invasion. And blood vessel inwards and eroded. I repeat again, blood vessel inwards and eroded by the trophoblast, then bleeding. Bleeding and erosion is the main cause of rupture. And what about the uterus? Uterus have same residual reaction occur in uterus. They have the same residual reaction, and with the endometrium changes in the there is a spatial exchange one. And here the no sac or it was increased vascularity, muscle hypertrophy, and in case of if you do ultrasound, there is a false gestational sac seen the uterine cavity. There is a special reaction occur in the endometrium that's called the Aristotle reaction. What is this? Aristotle reaction is a endometrium cell that changes in a said that the nucleus are hyperchromatic and cytoplasm are at first endometrium changes that you know about the in case of menstruation, endometrium changes secretory and proliferative phase. First proliferative, then secretory phase. In case of when secretory, then proliferative phase are absent. When proliferative, the secretory phase is absent. In here, in ectopic pregnancy, if you collected the endometrium, there is a secretory, mixed type of secretory and proliferative changes. Atypical, mixed type of proliferative and secretory changes, and these are nucleus are hyperchromatic, bizarre shape, and give rise to a false impression that maybe it's the carcinoma and other things. But It's the not carcinoma. And we also see these findings in carcinoma, choriocarcinoma, molar pregnancy. Also, these findings are also same in these cases. And this residual reaction maintained by function of the corpus luteum and the trophoblast. When there's mishappen overtaken, then this residual reaction is not maintained and bleeding occur in ectopic pregnancy. And other systems is a site-specific change at the tube and the uterus. And the general change, such as nausea, vomiting, as a normal pregnancy, breast change as normal pregnancy, there's pain. So there's some general changes in the ectopic pregnancy. Then we discuss about the pathology. What is the fate? This ectopic pregnancy. Have you any question up to this point? আমি এতক্ষণ যা পড়িয়েছি এটা কি সব বুঝতে পারছো না কোথাও কোনো কোয়েরি আছে বা কিছু মনে হচ্ছে যেটা আরেকটু ক্লিয়ার করলে ভালো হতো বা আমার বলার মধ্যে কোনো অসুবিধা আছে?
ম্যাডাম একটা কোশ্চেন ছিল।
বলো।
ম্যাডাম আপনি ম্যাডাম বললেন যে অ্যাবনর্মাল ব্লাস্টোসিস যেটা সেটা যদি ম্যাডাম নরমাল সেটা যদি ম্যাডাম হয় মানে ইমপ্ল্যান্টেড হয় সেটাও তাহলে এক্টোপিক প্রেগন্যান্সি। ম্যাডাম অ্যাবনর্মাল ব্লাস্টোসিস যদি ম্যাডাম নরমাল সাইট অফ প্রেগন্যান্সিতে যদি মানে ইমপ্ল্যান্টেড হয় সেটা কি ম্যাডাম আমরা এক্টোপিক বলবো?
না 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 না, এখানে তোমার এসেছে যেটা হচ্ছে অ্যাবনর্মাল ব্লাস্টোসিস যে হতে হবে এমন কোনো কথা, ঠিক আছে? তবে ইউজুয়ালি দেখা যায় যে ওই যে একটা কথা বললাম যে এজ বাড়লে ক্রোমোজোমাল অ্যাবনর্মালিটি বাড়ছে, হ্যাঁ, তখন অ্যাবনর্মাল ব্লাস্টোসিস। কিন্তু অ্যাবনর্মাল ব্লাস্টোসিস কিন্তু আপনার ইনটিউটেন্ট প্রেগন্যান্সি, ঠিক আছে? It's not a point fixed that abnormal blastocysts always occur in the ectopic pregnancy. No. Normal blastocysts, abnormal blastocysts, all can causes ectopic pregnancy and as well as intrauterine pregnancy. Okay?
Yes, ma'am.
Clear?
Thank you. Yeah, ma'am. Thank you, ma'am.
Thank you. আর কেউ? আচ্ছা, তাহলে আমরা চলে আসি এখন আমাদের ফেটটা কি হবে ectopic pregnancy. Usually বলবো না ঠিক, most dangerous one is rupture or abortion with hemorrhage. When ectopic pregnancy, usually when ampullary part, fimbrial part, ectopic pregnancy occur in the fimbrial part, then it goes to tubal abortion. And this tubal abortion are again complete or incomplete. In that cases, both are associated with bleeding. If it is incomplete, then it is a massive hemorrhage that leads to hemoperitoneum. Tubal abortion, that complete or incomplete, both are associated with hemorrhage. Okay, and incomplete is more dangerous. Rarely tubal absorption, যেটা absorb হয়ে যেতে পারে, it's a rare case, and it's rare due to the it's a small embryo, it cannot be identified or diagnosed. Another one is the tubal mole. What's the tubal mole? Tubal mole is near the choriodistal space. Repeated bleeding occurs, and it distended the tube and give a figure that's a more like figure bleeding. And it's happened usually missed portion when fetuses die in the tube, and then any hamper of the pregnancy, repeated bleeding causing distended tubal mode. Another presentation is the rupture. Most dangerous things. And after ectopic, you must know about the rupture ectopic as well as you pass the exam. And if you want to be a good doctor, manage the ectopic is must and conscious about the ectopic entity. Rupture is extraperitoneal and interperitoneal. Interperitoneal, that's the hemiperitoneal. Interperitoneal rupture leads hemiperitoneal, and this may threatening the life of the patient, endanger the life of the patient. Another is the extraperitoneal. Interperitoneal occur in the when the rupture occur in the roof of the tube, and extraperitoneal when the rupture occur in the ligamentary part of the tube, attachment of the ligamentary part of the tube. Here's the rupture and product the ligaments. Another fate is the chronic ectopic. In here, the bleeding occur, but subsequently arrested with moderate, mild to moderate bleeding, but this is arrested, no rupture or others, and then this forming a organized and forming a mass including tube, ovary, and blood clots. It's the chronic ectopic presentation. And have now the ectopic, the rarest possibility, the rarest outcome, the term pregnancy. Is it possible? Yes, it is possible that the ectopic goes in the term pregnancy. And what is the site? Site is the abdomen. In that case, rupture ectopic, but rupture is slow process, and whole of the amnion with living ovum are herniated through the range and settle into the abdominal cavity. Here, new vascular revision occur, a vascular connection, she got the vascular connection, and develop the fetus in the peritoneal cavity. আমার যদিও এটা দেখার সৌভাগ্য হয়নি, যে তারপরও তোমার সাথে শেয়ার করছে, এই বোধহয় 4 মাস হয়ে গেছে। 4 মাস আগে আমাদের এখানে একটা এই টার্ম পর্যন্ত চলে আসছিল, এবং এটা পেরিফেরিতে ওরা ওপেন করেছে, বুঝতে পারেনি ectopic, বোঝাও যায়নি হয়তো, ইউটেরাসের কন্ট্রোল বুঝতে পারেনি। পেরিফেরি করার পরে ওরা আর কিছু করেনি, দেখছে কি ওরা এটাকে ক্লোজ করে দিয়েছে, ক্লোজ করে আমাদের কাছে পাঠিয়ে দিয়েছে। তো রাতে ছিল যেটা আমাদের দেখা হয়নি, এটা দেখার সৌভাগ্য আসলে সবার হয়ও না। আমার লাইফে আমি দেখি নাই কখনো টার্ম প্রেগনেন্সি ectopic, কিন্তু জাস্ট শোনা। এবং সেই পেশেন্টটা আমাদেরকে রাতে আমাদের সিজার করার পরে, এবং লাকিলি there is a patient luck is very favorable that the placenta are implanted in the omentum. So we cut the omentum with placenta. So patient life safe, patient life was safe. And new vaccination occur in the, we are lucky the placenta, in that case is placenta insertion in the omentum. But if it inserted into the intestine, bladder, liver, anywhere, then it endangered the life. So when the diagnosis is ectopic, you must try to terminate it. Okay. কোথায় ছিলাম যে আমরা ছিলাম হচ্ছে টার্ম প্রেগন্যান্সি একটুপিক চলে যায় কিনা। আরেকটা বলে যে many years after the ectopic, undiagnosed ectopic, after many years is diagnosed as a not macerated, calcified or something, okay, lithopedion বলছে। The ectopic are undiagnosed and part of the fetus are come through the rectum, maybe possible. Then bones, lithopedion. Let me show clinical presentation. Clinical presentation, 90% ectopic and not beyond 6 weeks. Not continue beyond the 6 weeks. In case of Cornwall, then it's up to Cornwall interstitial. They go up to 4 months, but with a less common. Other tubal part to 6 to ampullary part is 6 to 8 weeks. Interstitial within 6 weeks. Okay. So presentation are 3 types: ruptured, unruptured, and chronic. But there's a classical trait. That is the ectopic pregnancy always present with short history of amenorrhea, abdominal bleeding, abdominal pain, abdominal pain and vaginal bleeding. A history of amenorrhea already discussed. There's 6 weeks, or even delayed period, 4 to 5 days, or even absent. History of amenorrhea, even absent. Maybe, usually short amenorrhea. Okay. And another most common findings, and in ectopic, we amenorrhea 80 to 85% patient have short history amenorrhea. Other 10 to 15% are delayed 2 or 3 days or no amenorrhea. And abdominal pain is the most constant feature in case of ectopic. And 95% patients have present with abdominal pain. And this patient pain are in case of ectopic, ruptures are first, it's a colicky agonizing pain. Okay. And patient feel and when it's a chronic, then a colicky agonizing pain is sometimes dull pain, converted into dull pain. In chronic case, first is a colic pain, then it came to a dull pain. The vaginal bleeding. What about the vaginal bleeding? Vaginal bleeding is slight, and this is the endometrium shed out. As a decidual reaction occurs in endometrium, this is a shed out causing the vaginal bleeding. And vaginal bleeding in case of 80 to 85% patients complain vaginal bleeding. And what is the classical type? Amenorrhea, abdominal pain, and vaginal bleeding. Short period of amenorrhea. You can make a very short period of amenorrhea, vaginal pain, and bleeding. Abdominal pain. Sorry, slip of tongue. Short period of amenorrhea, abdominal pain and vaginal bleeding. তিনটা থাকলে আমরা সাসপেক্ট করব হচ্ছে একটু এর সাথে পেইন এর নেচার when it is rupture then colicky agonizing severe pain chronic dilating and unruptured patient have a complaint about uneasiness on lower abdomen or any lateral one-sided uneasiness or one-sided iliac fossa, one-sided uneasiness, one-sided pain, not so severe agonizing. Other symptom, if you take a rupture, patient pain, usually patient pain in shock. This life. And here's the interesting things that the ectopic rupture ectopic presentation as a rupture presentation of rupture ectopic is less common than the chronic ectopic. 30% ectopic are present with rupture ectopic, but we are more concerned about the rupture ectopic because it needs immediate attention to save the life. The history, then we do examination. On examination, general examination, patient are ill looking, or if it a rupture, I discussed first rupture, and patient are pale, and first looking, the patient are conscious but pale, severely pale, and it's proportionate with the blood loss. If there's hemophilia, patient develop anemia, patient looks pale. On general examination, usually patient are in shock, or if not in shock, then the pulse or tachycardia will not decided the rest of consumer tachycardia, persistence tachycardia, hypotension is the common feature of ectopic pregnancy. On vaginal examination, parabdominal examination. General examination, then parabdominal examination. Parabdominal examination, abdominal tense, tender. Tense, tender, but mass cannot feel in case of sleep. But there may be fluid stiffness due to hemophilia. এটার মধ্যে এত বেশি ব্লাড হয়ে গেছে যেটা শিফটিং ডালনেস তৈরি করতে পারে। কেন the shifting dullness? Anyone? What is shifting dullness? Shifting dullness is the examination sign that's indicated the free fluid in the abdomen. Shifting dullness, এটা হচ্ছে আমরা ডালনেসটা দেখি অ্যাবডোমেনে এবং এটা আবার শিফট করে। আমি পেশেন্টকে যদি পোস্টার চেঞ্জ করে দিই, যেখানে ডালনেস পেয়েছি সেটা যদি পেশেন্ট পোস্টার চেঞ্জ করে দিই তাহলে সেই ডালনেসটা শিফট করে যাচ্ছে। এটা হচ্ছে shifting dullness. And parvaginal examination. Parvaginal examination, patient are slight bleeding. Bleeding is not severe. And if you do bimanual examination, then most important finding is the cervical excitation test. There's the patient feel tremendous pain when you move the cervix. And there's a bulging the fornixes due to peritoneum or mass. But mass, in case of acute cases, mass cannot be felt definitely. But in case of chronic case, in parvaginal examination, if cervical excitation is positive, I means that the patient feel pain when you move the cervix, and we also find there is the mass in the adenoid, the feature of chronic ectopic. And but here cervical excitation test is the most diagnostic on examination, the most diagnostic feature. But this tremendous pain, so it cannot be elicited or patient in shock, so patient cannot responding pain. Okay, so we depend for diagnosis the classical triad ectopic. In case of rupture ectopic, classical triad is the most important factors. Okay. That's the other, I say, short period of amenorrhea, abdominal pain, and vaginal bleeding. And for diagnosis, we always suspected that if any patient, sexually active woman, reproductive age, have any abnormal abdominal pain or any abnormality on bleeding, we must suspect it ectopic. Suspicion is most needed. And now we'll discuss about the investigation. I also say I now say that we also said that the classical triad is the most important finding for diagnosis of pregnancy. About when a patient comes in rupture or in shock, have no time to prostrate to do the laboratory investigation. We only do the hemoglobin and blood grouping. So clinical diagnosis with triad and vaginal examination is the most important finding in case of rupture. In case of chronic, then you have to many investigation. Another common we do common investigation. There's the urine for pregnancy test. Okay, it's the bedside, can be done in bedside procedure. So if a patient with classical triad, amenorrhea, abdominal pain, vaginal bleeding, and pregnancy test positive, then you must suspect it. It's the ectopic. Another one is the beta histology. If beta histology is helpful in diagnosing the unruptured ectopic pregnancy. That's the beta histology when unruptured or chronic ectopic is helpful. Beta histology doubling time. This term is doubling time. When you do beta histology and you repeat the beta histology after 48 hours. If beta histology failed to raise more than 66% than the previous reading, then suspected that it may be ectopic or non-viable pregnancy. তার মানে 40 আমি প্রথমে বিটা এসএসজি করলাম 48 আওয়ার্স পর আরেকটা বিটা এসএসজি করব সেটা যদি আমার বিটা এসএসজি রাইজটা 66% এর নিচে হয় তাহলে আমি ধরে নিব এটা একটা নন-ভাইবল প্রেগন্যান্সি অর ectopic pregnancy. Another this diagnostic tool is the ultrasonography.
ম্যাম কথাটা আবার একটু বলেন।
First we do a beta ECG, okay, first day, and repeat beta ECG at 48 hours, after 48 hours, and reading to be 66% এর beta ECG বাড়বে, ঠিক আছে? আমি 48 hours পরে ডাবলিং টাইম বলি আমরা, হ্যাঁ, beta ECG বেড়ে যাবে। কিন্তু যদি দেখি এই বাড়াটা বাড়ছে না, লেস দ্যান 66% হয়ে গেছে, বাড়া মানে হচ্ছে মোর দ্যান 66%। ধরো আগে যদি তার 100 থাকে বিটা 1000 থাকে, যদি বিটা 100 থাকে বলি আমরা, যদি 100 থাকে 48 আওয়ার্স পরে 166, মোর দ্যান 160, 170, 180 হতে হবে, ঠিক আছে? কিন্তু দেখা গেল এটা 140 তে চলে আসছে, 120 হয়েছে, তাহলে এটা আমরা বিটা এসএসজি ওই 66% বাড়লো না। ওকে, দেন আমি মনে করব যে আমার, কিন্তু ইন কেস অফ ইন্টিউটেরিয়াল প্রেগন্যান্সি দেন বিটা এসএসজি more than 66% rising. Okay, clear? ঠিক আছে, বুঝতে পারছো?
জি ম্যাডাম।
আচ্ছা, ঠিক আছে। এটা হচ্ছে আমাদের একটা ডায়াগনস্টিক টুল। is important in, again say it's important in unrupture and chronic. Okay, rupture it's a beta is a time consuming procedure, so when you wait for the beta the patient are to lose the patient. And then the TVS is more informative and TVS is more early, can diagnose the ectopic. When beta is a 1500 international unit per liter, then TBS can diagnose gestational sac in the uterine cavity. So, if we say the beta ECG is more than 1500 international unit per liter, but empty uterine cavity, then we suspected it may be ectopic pregnancy. Transvaginal sonography, but it is a transabdominal sonography. Transabdominal sonography in uterine pregnancy can diagnose when beta is more than 6 weeks or beta ECG is more than 6,000 international unit per liter, then transabdominal diagnosis can diagnose the intrauterine pregnancy. When beta is more than 6,000 international unit per liter, but transabdominal says there is no intrauterine pregnancy, empty uterine cavity, only thickened, then it's suspected it's a ectopic pregnancy. Here is the combination of transvaginal ultrasonography and beta ECG. We discuss about this because this ectopic is the confusing, so much confusing topic. So when actually when the chronic or unruptured, then this combination are needed to diagnose the beta ECG, diagnose the ectopic. And there's another diagnostic tool is a laparoscopy. Is direct visualized and it has others benefit that at the same time it can be as a treatment purpose, used as a treatment purpose. And last of all, I want to say that it's laparoscopy and also laparotomy. Why we say laparotomy is in investigation? কেন আমরা ল্যাপারোটমি ইনভেস্টিগেশন করছি? কেন বলা হচ্ছে যেহেতু এটা সাসপেক্টেড ectopic. If you suspected a rupture ectopic, then you open the abdomen and you have no assume or shame that you open negative. You open and see that there's a negative, no ectopic. You have no shame because if it was ectopic, then save the life. মানে আমি যদি ectopic আমি অ্যাবডোমেন ওপেন করলাম সাসপেক্টেড চিন্তা করে আমি পেলাম যে কিছু নাই, তারপর ডক্টর সোসাইটি অন্য কেউ তোমাকে দোষ দেবে না যে এটা কেন করেছো, কারণ হচ্ছে ectopic এতই ডেঞ্জারাস একটা জিনিস, তুমি যদি ওপেন না করো তাহলে তুমি পেশেন্টটাকে লস করবে। তো আজকে বোধহয় আমাদের টাইমও শেষ, আমি ডায়াগনস্টিক পর্যন্তই বলতে চাচ্ছি। আমরা এরপরে আমার বোধহয় তোমাদের সাথে আরেকটা ক্লাস আছে 8 তারিখে, সেদিন 9টায় আমি বাকি ট্রিটমেন্ট এবং যে কর্নাল বা আদার সার্ভাইকাল যে ইন্টারভেল এগুলো নিয়ে আরেকটু ডিসকাস করবো। এখন এটুকু যতটুকু বললাম এর মধ্যে তোমাদের কোনো আর কিছু জানার আছে কিনা বা বুঝতে আর কোথাও কোনো সমস্যা আছে কিনা? এনি কোশ্চেন? আচ্ছা, তাহলে হয় তোমরা সব বুঝে গেছো, না হয় কিছু বুঝছো নাই। কোনটা? হ্যাঁ, আমি আশা করবো সব বুঝে গেছো। আমি যেহেতু বলেন এতক্ষণ ধরে প্যাট প্যাট করলাম, তাই আশা করতে হবে নাকি? আচ্ছা, এনি কোশ্চেন? ওকে, যদি কোনো কোশ্চেন না থাকে, কোনো কথা না থাকে, তাহলে 8 তারিখ পর্যন্ত তোমাদের কাছ থেকে বিদায়। ঠিক আছে, নেক্সট 8 তারিখে আবার দেখা হবে রিমেইনিং। ওকে, থ্যাংক ইউ অল।
Thank you, ma'am.
আদাব ম্যাডাম।
আসসালামু আলাইকুম।